This person approached us about understanding their physical problems. And we're not going to actually mention the symptoms just yet. We'll get into those in a bit. But we're going to take a close look at how things are sitting structurally, how things are proportioned, and why that might lead into the symptoms, or why that might even create the symptoms. This is often a better way of doing things because it forces us to take a blind look at how anatomy is put together, the structural analysis of things, and from that make some guesses as to what the symptoms might be. When we can do that, we can relate structure and function, and this means that they follow a certain sensical order, and they're easy to relate to one another, which means it should be, after the fact, easier to fix the problem, were that your goal. But before any of that, let me just say, I'm not a doctor. None of this is medical advice or a medical diagnosis. It's for educational, artistic, and I'm going to say entertainment purposes only. Because I'm entertaining, right? Yeah. And I have to do this at a distance too. That's important. So I'm going to use images, and I've screen captured from some videos, so I can't directly touch things. Based on that, it's going to be educated guesses at best. And I'm going to be wrong in a few different parts, and I'm okay with that. I'm going to be right about a bunch of stuff too, frankly. But I'm going to be wrong on a few things. We may disagree, and I'm okay with that. I'm okay with that anyways. So, let's look. Hopefully, when we're scanning around there initially, you noticed this big thoracic curve. I don't know how you could miss it, but this particular person, they'd seen a few therapists with little to no help. And when you miss something that I feel is this obvious, it shows a bit of a lacking of integrated anatomic understanding. When we work our way through this, I hope it'll be obvious as to why this person's having the symptoms that they're having. And I'm going to try and make sense of that as best as I possibly can. Try to make it so that we all agree that they should be having the symptoms they're having because of the way the structures are proportioned. So this big thoracic curve here is too much. Notice how the lumbar spine is actually curving so far forward in extended position that it's being obscured by this arm here. That should not be the case. It's as if it was shoved forward. I don't think that's how that worked. I don't think this was a traumatic injury necessarily, not one in particular, maybe a few, but I don't think it was one specific event that did that. But this thoracic curve in particular is way too much. You'll even see it's got a nice kind of flat part right there. These are big compensations, and it goes back into an extension curve there, again pushed as if it was pushed forward in the neck. Now in a way these are normal curves. This is what the spine's supposed to do. We're supposed to get this extension, flexion, extension, but not so extreme. And this is where we can kind of get caught up. We say, oh, these are normal spinal curves, but are they within normal ranges? Now the apex of this curve seems to be, and we're going to back this up, seems to be just right about the tip of the scapula, so right in and around there, or from a side view, and I did this on purpose, right in and around there. We need other viewpoints to justify this, but this ain't a bad start. Another thing that's worth looking at is in a full flexion, you can see this apex really pop out. You can see how blatantly obvious it is. So if I just draw a straight line there and a straight line there, you can see how pointed it is. Let me do that better. Straight line there. You can see how pointed it is. And this means it's favoring that motion, but favoring it to such a degree that we've probably had some anatomic change. If I had to guess, there's been some changes even at the vertebral level. Let me just change my pen size there a little bit. So at this, 6, 7, 8 area, this is an exaggeration of course, but at the 6, 7, 8 area, probably had some change in position, a little bit of translation, a little bit of shortening, even a coming together of the ligamentous connective tissue, and even muscular structures. Not a ton of muscles in the front of those vertebrae, but this is where I'm guessing it's really getting kind of pushed together. That flexion curve, the whole point, him going into this forward bend, rolling down like so, is to exaggerate, and we've heavily exaggerated. It should be a nice smooth curve. It should go more like I can do better than that, more like that kind of thing. But it's not doing that. It's very clearly not doing that. So we know that one particular spot is taking on a lot more than it should. It's quite stuck in that position. And then to further prove that point, doing the opposite, going into extension, we should actually see, in normal anatomy, which we should see a reversal. So he's gone backwards, we could call it, but we call that extension, spinal extension. And notice the width of the thorax when we do that. He maintains this curve through here. This sticks around, even though it should not entirely disappear, but should be much reduced. It's still pretty pointed in this particular spot. So we know something's really stuck in that thorax. We know something's pushing backwards. And there are, in fact, a few things, as we'll see in the next images. Let me just clean some of this up first, just to tidy it up, get rid of that through the magic of technology, and another view. So, in our front back view, we had some side views first. We started there for a reason. You should just pick up kind of, again, obvious things to start with. Throw a line there, throw a line there. And hopefully right away you see one area of difference just between the shoulders. So you've got a kind of smaller space here and a kind of larger space here. This is the right side, and this is the right side because now he's facing the front. And it's fairly consistent. Smaller space on the left, bigger space on the right. So we can say that the scapula, and I'm not saying the shoulder as a whole, but I'm saying the scapula, at least taking the shoulder and the arm along with it, is dropped down. So our posterior view of the skeleton, I'm just going to throw that on there. And just so we're clear, the scapula is down. I'm going to say, though, based on that, and I'll qualify it a little bit, I'm going to say it's actually the thorax is not coming down like that, is not bent to that right side. That's a fairly common misconception that that's what happens. We would think, and you could do this, if you just bent yourself to the side, if you just bent yourself, you took your body and dropped it to the right, you could get the scapula lower, but you would also be, like this. Your head would be here, and that's a bit silly. It's counterproductive. The body just doesn't do that. So what often happens is we actually have a curve side bend that way, with the upper parts going like this. We can get more complicated than this, but it goes like that. But there's definitely, more than likely, a side bend to this left side, and it's sticking out here in a big way. So that should be the case. This is almost a consistency. Though the shoulder is down on one side, sitting underneath that shoulder, this rib cage here is actually bent the opposite direction. It's bent to the left, like that. Hold on. There we go. Hey, there we go. Okay. More like that. That's what I'm saying is more or less happening. Now, just another quick look at this. If we just pull off some of that. There we go. Get rid of that. Don't need it. Notice we've got some discoloration happening here. Notice we've got some discoloration happening right here. That's probably something stuck back. Again, we're right at that apex there. That's probably something sticking back at us a little more on the right side. We don't see it nearly as much on the left, even though we've got a bit of an indent here, indicating the exact opposite, in fact. But we'll get to that. So when we have them flex forward, and these are two images, one slightly more bent forward than the other, but this is from a posterior view. So we're looking at it from the back. We have them bend forward. This one's a little less bent up top here than this one down here. But in any case, notice in both of them, you can clearly see that we have a rib side that is closer to the line here. It's higher up. So this one here is sticking further back than this one. This one's by comparison down. again, if we do the same thing as with the shoulders, we've got a little bit of space here. Sorry, we've got more space here. We've got tiny little bit of space here. Same with this. So we can say this side's probably rotated backwards, and by comparison, this side's rotated forwards. And again, I want to relate it to the apex of that curve. That's where I think it's happening. And we established it was right about here. It seems to match up nicely in and around this T6, T7 area, a little more T7. Let me just get that brush size a little bit better. There we go. There we go. In between the vertebrae ribs come around. You've seen these, I'm sure. And there, come around that way. And so probably these ones are actually on the posterior side. These right ones are going back like that. It's a smaller rotation that I've drawn here, but it seems to be a rotation. So we've got some real points where it's stuck. It's pulling back on us. This changes the way the muscles work. This changes the way the body works as a whole. I'm saying this one's pretty rigid. That's an important point for later, but it seems to be a pretty rigid thoracic spine. Let's take another look. Get rid of that view and take that one on too. Now we've got some accessory stuff that even though you could kind of work just honestly solely off the thorax, we've got some other stuff going on here too that's going to relate to the symptoms we've had. We're going to run through those one by one, but notice the position of the neck. Again, we've got this thorax here that we're interested in. We've got the extension of lumbar spine. That's important too. But look at the hitch we have in the neck. There is supposed to be a prominent part in the neck. A prominent part. This one's about a segment too high. Normally, it's about C7. It sticks out, vertebra prominence for a name, but it's actually more at the C6 region, if you will. There's a bit of a hitch, and we're actually getting a fold, another fold at the higher cervical area. So again, it's sticking forward as if C7 had almost been, kind of pushed forward. There, we're getting some interesting things. These are two different points of flexion, of course, but it's showing the neck as a little bit hypermobile. Going back to that original picture, let me just get rid of this one for a second. Going back to that first picture we took a look at, right there, this type of a curvature, this extension, and then sharpen to almost a flat position. It's not even flexion, it's flat. And then into a harder flexion here. It was just telling us something's up. It's really a continuation of the thoracic curve causing the head to be forward in position. But when we really look at it, when we take a look at the neck in more of a full flexion, like bent right down, we can see some of the flattening in this mid part, some of the flexion at the upper part. I'm saying around C2, C3, and then even some like posterior translation, anterior translation going on C6, C7. These are pretty pivotal areas because they have an influence on the brachioplexus, but they also have an influence on the stability of the shoulder, and they make it so it's capable of stabilizing, of moving properly. So we got to throw that in, of course, to our model here. So we've definitely got more of a curve like this. We'll do it even, I'll give it a nice straight line, increase my brush size a little bit there. Do it in red. There we go. There, and then probably a little bit of a flexion right on that C2, C3 area. Again, pivotal points. And I can't prove this fully, but I'm really going to guess more of a rotation that way, more to the right. Side bend rotated to the right in the neck there, just based on what I'm seeing. Now, let's throw up some of the symptomatology, some of the things that we're going to relate to this particular person and see why what we see structurally makes sense. And then I'll throw a few more pictures in. So let's start at the beginning. Let me get rid of this actually. Hold on. Space this out properly. There we go. So the main complaint is that the shoulder is slipping and clicking. So this person, came to us and said, "Hey, I don't know why this is the happening. I don't know. Nobody's able to tell me why this is happening." And again, to me, it seemed a little more obvious as to why this is happening. But I was looking at more of a full body picture. There's a trick to working in the manual therapy field, and it's don't be distracted by the loud sounds and don't be distracted by the pain. They're indicators of a problem, but they may not be the problem themselves. And in fact, oftentimes, unless they were specifically struck in that area, unless they went through a car accident that impacted that area directly, it's almost always never the problem. The thing that pops is actually moving, and so it's not the problem. The thing that hurts by comparison, that's not what we're talking about here, but the thing that hurts is almost always on the opposite side of the issue. It's being strained, but it's not stuck. So we can't be distracted by that. So the shoulder, and it was the right shoulder in particular was the one that was having the problems. It was having the problems of popping and clicking, and then just going back to our original pictures here. Let me just get rid of some of these extra lines there. We have a good case for that, just to start out with. Because of the fact that we've got a very stuck thorax. Again, look at the root of this. Because we've got this thorax that is basically shaped kind of ovalish and rigidly stuck there, we start to lose our base of support for that shoulder's normal motion. When we have a big side bend through here, ribs sticking back on this side, and a scapula that's dropped, we really can't expect that shoulder joint to behave normally. The shoulder joint pulls off the scapula. And actually, it pulls from shoulder, so true shoulder joint being head of humerus, all the way down that arm. That's the real shoulder joint. It relies on the scapula to move effectively, but that scapula is pretty much entirely held by muscles. It's truly a floating joint. It's what gives it the ability to drop down independent of the thorax. They're related, but the scapula can really drop down. So it's got, say, the trapezius muscles, rhomboids, all that stuff, holding it to the thorax, holding it to the thoracic spine. So when the one is off, you can't expect the other to behave. This does bring us to our second symptom, constantly tight muscles around the scapula. And again, this does make sense. If the thorax is heavily bent through here and the scapula is sitting at a funny angle, especially if we have a side bend here and we have ribs literally pushing back into that scapula, it's going to be tipped forward a little bit. It's going to be doing this funny protraction, weird oblique axis of rotation going kind of like that. These are not ideal positions, understand. And so the scapula is going to definitely be altered by that fact. So it turns out when we start moving that shoulder joint in bigger and bigger motions, and we'll get into what those are in a bit, we're going to ask it to essentially hyperextend. Now the right one's a problem. I'm just going to draw on the left. So if you were to be reaching up for a cup, or I don't know, something else that we'll talk about later, you would not have the normal give that you have here in this thorax. You would not have the ability to bend up, prop that scapula up, because it's technically being pulled down improperly by the traps with this curve that's going on. You would not have the bend through the thorax or through the neck to support that scapula. And so what you're going to end up doing is instead of contributing to things with the scapula, you just end up pushing the shoulder forward. We all do this in some way or another. We call it compensation, we call it unified mechanics, whatever you want to call it. Doesn't matter. It just means that all the parts have to work together if you want a full range. And when some of them stop working properly, it means we just push harder and harder the ones that still work. The workers, as usual, as always in any group, the workers that are still capable of working, that are working harder, often get more put on them, even though it makes more sense to get the ones that are lazy, that are not doing their job, to do more. Unfortunately, that is how the human body tends to work. In addition to that, we've got this tight around the scapula, so we're trying to hold on to it. It's trying to bind up to the thorax. So we've lost scapular motion. We have very little thoracic motion. That's just a rock. So neither of those things are moving very well. So we're hyperextending the shoulder. Now, he mentions he broke his arm in middle school. apparently that happened. I don't think that's hugely important. It might have set some things in motion, but the way he described it was interesting, but I don't think it's super relevant because it just didn't. The mechanism in injury doesn't seem to be there. However, one thing he did mention, and that's the reality, sometimes patients will just say stuff that's not important, and it's interesting, but you don't need to do anything about it. One thing that was relevant was he mentioned some bad lifting, very bad lifting in high school, as most people do. You know, you get into lifting, you want to put on some muscle, you want to put it on fast, and you go, hey, I'll just lift a whole bunch of weight. And that does justify a lot of what we see here. So imagine for a second, just consider, we'll throw in some better anatomy. Ooh, missed something there. Some better anatomy. The form of the shoulder joint. We're lifting heavy because we're not doing it with good technique, and we are pulling really, really hard, which you have to understand about weightlifting. And this is every single age. It doesn't matter how old or young you think you are. You need to have good technique because poor technique builds in poor positions. And if we're doing weightlifting where it's in front of us, because who does anything but arms and chests? If we do weightlifting and it's in front of us, it's going to pull through that arm, it's going to yank down on here, and if our back is not set up right, and there's lots of different ways of doing that, there's a few different ways of doing that properly. If our back is not set up right, it's actually going to yank us forward into pretty much the position we had here, where normally, and what's supposed to happen, is that weight of your body plus the weight of the barbell is supposed to be placed smoothly and evenly through the spine, and then even down into the legs. It's supposed to hold it as a unified structure. It's being localized onto one spot. So chances are he was doing this, you can see it there, mainly he was doing this with a flexed lumbar spine. He's really allowing that to go too much into that, and that was making it so the more of the weight was being put there and more of the weight was being yanked forward, and so we created this nice apex to his curve right at that point. And so it folded up. It gave us this forward bending, we'll say a general compressed, not like a true medical dangerous compression, but a compressed position, a compression of structures. And so it allowed it to come together more than it should. And now it's stayed there. It's actually deformed along those lines. Not permanently, it can be reduced, but it's caused a very, very stuck thorax. Again, that more than anything seems to be related to the shoulder popping and clicking, the main complaint. We also have a basketball player, which is cool, which takes it just that one step further. Now this person, the reality is, many people would never notice these kind of things. You can go a very long time in your life, like a very long life, without ever noticing some of these problems. Let me just pull away some of this. So oftentimes we have issues and, they're in there structurally, but they never get fully expressed, or they wait till way later in life to actually show up. But when we take on certain sports and activities that accentuate motions, we're going to notice some more. So the fact that this person is a basketball player means they were doing a lot of shooting. And he gave us this picture. We didn't even ask for us. He was pretty sharp. That's not what a basketball looks like. There we go. Okay, basketball. Pretend he hasn't quite shot it yet. And I think there's some lines on, I don't know, basketball. Anyways, I know hockey like a little bit. There we go. Lines, something like that. There we go. That's sort of basketball. Anyways, you're constantly doing shooting in basketball. You practice, you do a lot of that. Right away in this picture, and this is just, always go on first impressions if you can. Do you see the bunching up, the almost puckering we're getting going on at this shoulder? This is indicating that shoulder joint that we're talking about, let me get rid of that, shoulder joint has probably been dropping down too far. Right away, we can kind of just see that. This is an indication, and I'll justify it a little bit further, but that shoulder joint, again, it's on the right, but I'm drawing it on the left just for clarity's sake in this image. As it comes up, the shoulder joint is uniquely made. The hip does not do this by comparison. The other ball and socket joint does not do this. The shoulder joint is uniquely made. There's got a little bit of a gap in its capsule. So like, if we just make a much bigger version of this, there's the joint itself. There we go. And there's the scapular attachment. Well, the shoulder joint has a little bit of looseness. It's got almost a bit of extra space so that when we abduct it, that capsule, which in any other joint would be tight and circumferential, well, the shoulder joint has actually got a bit of extra space so that when we bring it up like that, it drops down. It actually has the capacity to fall into that gap so it can go much, much further. Again, we can't do that with our leg. It'd be actually a terrible idea to do that with our leg. Imagine if you could bring your leg that far out and basically kick yourself in the side of the head with your own leg. Maybe there's a few people can do that, but I mean, I don't think it's a normal, I don't think it's a suggestible level of flexibility. So anyways, the shoulder joint has this kind of built-in designed laxity, but it shouldn't go nearly this far. When we see this puckering that we got going, when we see basically the deltoid muscle folding over, and what would normally be a nicely proportioned muscle right there has actually collapsed a little bit. So it's actually dropped down. That's our first indication. Another part to this too is you can see it here again. We've got a more prominent area here on the back, indicating we've got this kind of rotation. But notice the scapula is not really all that high up. We've still maintained, even though he's got his arm totally up, we still maintained a relatively low scapula. We should be having a little bit of a bend in the spine. He should be coming up with the arm. He should have the scapula raised up to a little bit higher level to assist with the shooting of that, bring the arm, but we're not getting cohesive motion throughout the body. So he's using pretty much entirely his whole shoulder joint to generate this abducted position and this what we call flexion from the side. This is one of those weird things, but this is called flexion when it comes to the arm. So when the arm goes up here, that's considered flexion. I don't like it either, but that's just the truth. So him bringing the arm up to this height and then moving the weight of that ball, even though that ball does not weigh a lot, it's still like pressure on that shoulder. It gets translated back through the arm and pushes it down when you go to shoot. So it's a lot of weight. And over the course of many, many years, if we don't have the normal compensating mechanisms, if the weight of the ball doesn't transfer through that arm and that arm does not push it into the scapula and the scapula does not get caught up by the muscles of the thorax and the thorax doesn't properly suspend that weight evenly and balance it out the entire structure, and then eventually it goes all the way down to his toes, and technically it does. I know it's convoluted, but technically it does. If that's not happening, then he's going to see some problems start to show up, mainly in that shoulder joint. It's going to become hypermobile. It's going to start clicking and popping. So this is not one problem. Clicking and popping in the shoulder, not a big deal. It's an effect. Don't get distracted by it. It's a matter of figuring out why something else or why a number of structures allowed it to click and pop. So these are the important things. These are the things that make it all worthwhile. We've also noticed, before I get into that, generally he mentioned he was too flexible at his joints. Now, this is not a connective tissue disorder as far as we know. He was not medically diagnosed with it, so we're going to go with that. He's had no reason to be thoroughly investigated for that type of a medical diagnosis, but it seems to run in the family a bit, but not severely. So it's probably not a true connective tissue disorder. What we have noticed, though, and this is not evidence-based, this is one of those clinical concepts, when someone is really, really stuck in a certain area, when they are particularly rigid in one spot, and especially when we're looking at this kind of a thorax, this kind of a rigid thorax, they will tend to be hypermobile in other spots. So even though he does have some extra mobility in the shoulder, so the shoulder is suspect. Really, it'll be both, because you can't have a thorax like this and not have both shoulders doing a little bit of hyperextension. But when we have a really, really stuck spot in one place, something else has to give. This is almost a general rule. A few of the areas, so the shoulders is certainly one, but a few of the areas will be this neck. You can see it's been driven forward, and then you can see it's in the lumbar spine again. We're guessing that the hips have a problem. And we're not going to make too many assumptions. We did kind of look at that in some of the videos and screen caps we grabbed, but it wasn't worth going into in this particular section. That would be something we'd want to explore. There was also some significant back pain noted by this person, but we feel that's kind of obvious as to the fact that this is so far pushed back, that this has to be so far pushed forward just to get him looking straight forward without being hunched over all the time. And so you've got quite a bit of pressure being exerted on the posterior part of the spine. Too much pressure on the spine on that backside. Those facet joints are being really, really loaded in an excessive way. Some of it should be a little more balanced between the front and the back. So we can kind of clear that one up quickly. But that would have to be really addressed as a progression. You want to fix this first. Getting this sorted out is the most important thing. But that being said, that rigidity, flexibility thing is very much a related series of concepts. They have to work together. What you lose in one, you often take from another. And that's what's going to help actually fix this in the long term. Whosever hands he gets put in, because it won't be mine, because we could be oceans away as far as I know, but whosever hands he gets put in, hopefully they will understand, hopefully they'll be able to see some of the rigidities in the body and how those have gone into creating hypermobilities, excessive motions in the body. And not to get distracted by those, not to get distracted by clicking or where there's some pain, but looking at what really doesn't move and what's forcing other things to move in very different ways they should not. As always, this has been Alg for Simple Lines Anatomy. I hope that made sense. I had a fun time doing it, so, at least there's that.